Let's get straight into it. When we're talking about ENT and pediatric airway emergencies, airway stability is absolutely your #1 clinical priority. For board exams and real life, the next best step decision logic mandates that you assess the airway before initiating literally any other diagnostic step. If you miss impending airway failure because you're busy ordering imaging, you failed the scenario.
Section 1. Airway triage and red flags.
Now, if a patient rolls in, drooling, looking toxic, refusing to lie flat, or sitting in that classic tripod position, your entire algorithmic approach has to shift immediately. Things like severe respiratory distress, hypoxia, a muffled voice, or stridor while just resting. These tell you the obstruction is rapidly worsening. Seeing these signs shifts your next best step entirely away from getting imaging or doing any provocative throat exams and moves you directly toward definitive airway protection.
Moving on to Section 2. Sinusitis and septal trauma.
We know viral upper respiratory infections are super common, right? And they generally improve by days 5 to 10. But acute bacterial rhinosinusitis requires specific diagnostic criteria to pull the trigger on antibiotics. You're looking for persistent symptoms that just aren't getting better for 10 days or more, or severe symptoms, like a fever over 39 degrees Celsius with purulent nasal discharge or severe facial pain lasting at least 3 days. The tricky one is double worsening. That's when a patient gets a brand new fever right after they initially started improving from a viral illness.
When it is bacterial, it's usually driven by non-typable Haemophilus influenzae, Streptococcus pneumoniae, or Moraxella. For these, your first-line pharmacological intervention is amoxicillin clavulanate. You absolutely want to avoid macrolides, standard amoxicillin, and trimethoprim sulfamethoxazole because of high local resistance patterns. Also be on high alert to evaluate for complications immediately if you see orbital findings, a severe headache, a toxic appearance, or any neurologic signs.
So, following nasal trauma, you need to quickly triage for epistaxis. Manage your common anterior bleeding with forward-sitting, firm pressure, and topical vasoconstrictors. Escalate to packing if it persists. If it's posterior or unstable bleeding, that requires immediate hemodynamic attention. But alongside that, you have to evaluate for a septal hematoma. This is a fluctuant swelling of the nasal septum, and it is highly dangerous. Why? Because the underlying cartilage relies completely on the overlying perichondrium for its blood supply. If that gets separated, you're looking at avascular necrosis.
So your next best step here is prompt surgical drainage. Getting that drained immediately prevents infection, septal perforation, and a really unfortunate cosmetic saddle nose deformity. Actually, if a patient comes back weeks after rhinoplasty or facial trauma and they've got a whistling noise when they breathe, that is the classic presentation of a missed septal hematoma that went on to cause a full septal perforation.
Section 3. Deep neck space infections.
Let's look at two critical lookalikes. A paratonsillar abscess is going to present with fever, a severe sore throat, dysphagia, a classic muffled hot potato voice, trismus, and pooling saliva. Contrast that with a retropharyngeal abscess. This often follows a viral URI or penetrating pharyngeal trauma, like a kid swallowing a fishbone. This one presents with severe neck pain, limited neck extension, drooling, and a retropharyngeal bulge. Take a look at this. The classic physical exam finding for a paratonsillar abscess is this massive unilateral tonsillar swelling. That swelling acts just like a mass lesion, physically shoving the uvula totally away from the affected side. When you see that uvula deviation paired up with a severe sore throat and trismus, you've confirmed a paratonsillar abscess.
And again, airway stability is your very first priority here. If the airway is secure and your exam is classic, your next best step is needle aspiration or incision and drainage, followed up with intravenous antibiotics. However, if you're seeing signs of a deeper neck infection, you need to hold off and get a CT of the neck with contrast.
Now, in a retropharyngeal abscess, imaging is going to reveal massive widening of that prevertebral soft tissue space, while a lateral X-ray, like this one, shows that characteristic thickening beautifully. A CT scan of the neck with contrast is actually your definitive imaging choice. You need that to define the extent of the disease before you initiate airway protection, IV antibiotics like ampicillin sulbactam or clindamycin, and surgical drainage.
The anatomy here is absolutely crucial. Right behind the retropharyngeal space is a fascial plane we literally call the danger space. This space extends continuously from the skull base all the way downward, directly into the posterior mediastinum, reaching down to the diaphragm.
Because of this continuous anatomical highway, an infection in the retropharyngeal space can spread straight down into the chest. This causes acute necrotizing mediastinitis.
It's a highly fatal complication, and it's exactly why prompt recognition, IV antibiotics, and surgical drainage are so critical. You do not want to wait around on this.
Section 4. Pediatric Airway Emergencies.
Let's break down 3 major pediatric presentations through pattern recognition. Croup is typically your viral parainfluenza infection. It presents with that classic barky cough and inspiratory stridor, and it improves with dexamethasone and nebulized epinephrine. Epiglottitis is bacterial, causing high fever, drooling, tripod posture, and rapid airway obstruction. Then you have bacterial tracheitis, usually caused by Staph aureus following a viral URI. The absolute key differentiator for tracheitis is a toxic-appearing kid with a high fever, thick purulent secretions, and croup-like symptoms that simply do not improve with racemic epinephrine.
Check out the classic radiological finding of epiglottitis here. This is the thumbprint sign. It's a massively enlarged, swollen epiglottis just pressing right into the airway. If you suspect this clinically because the kid is drooling and in a tripod position, absolutely do not agitate them with a provocative throat exam. Just don't do it. Secure the airway first.
And just a quick note, this doesn't only happen in kids. Adults can get epiglottitis too. They'll present with a severe sore throat, fever, muffled voice, pulled secretions, and you'll see a very similarly thickened epiglottis on their lateral imaging.
Managing this requires urgent airway intervention. You're going to start with bag valve mask ventilation using 100% oxygen, followed immediately by endotracheal intubation, ideally using a video laryngoscope. If your attempts fail, you proceed straight to a surgical cricothyrotomy to bypass all that swelling. At the same time, get them on broad-spectrum IV antibiotics, specifically ceftriaxone plus vancomycin.
Finally, Section 5, Foreign Body Aspiration. Foreign body aspiration is classic in an infant or toddler. The story almost always starts with a sudden choking episode, followed by focal unilateral lung findings. You're listening for a unilateral wheeze, focally diminished breath sounds, hyperinflation, or atelectasis. Now, if it's a nasal foreign body, that presents as unilateral, foul-smelling, purulent, or bloody discharge. And keep in mind, if the object is a button battery or a magnet, that requires urgent removal because the risk of tissue necrosis and septal perforation is huge.
Here is the absolute golden rule for foreign body aspirations. Following a sudden choking episode with persistent unilateral wheezing, a perfectly normal chest X-ray does not exclude a foreign body. Not even close, because many objects are entirely radiolucent. If your clinical suspicion remains high, you have to proceed directly to a diagnostic and therapeutic rigid bronchoscopy. You have to rely on your clinical exam to drive that next best step.